Let us begin with this discussion on 15th of January. Okay, this is the festival of Sankranti, which is marked by Sankraman, and this Sankraman in the dosage of amoxicillin also will be discussed today. We usually use amoxicillin in the dose of 40 to 50 mg per kg, but now Sankraman to the dose of 90 mg per kg, we will be discussing as to where it is required. We all know that, the respiratory system consists of the upper respiratory tract and the lower respiratory tract. Now, whenever a child gets rhinitis, it is obviously most commonly viral. When he gets tonsillopharyngitis, in almost 70% cases, it is viral, and in 30% cases, it is bacterial, wherein the group A beta hemolytic streptococcus is the main bacterium, and it fortunately still responds well to the beta-lactam antibiotics like penicillin, ampicillin, amoxicillin, and so on. Near the upper respiratory tract, and the brothers and the sisters of the upper respiratory tract, like the sinuses and the adenoids and the middle ear, they are all by the side of the nasal cavity, of which sinusitis in majority of the cases is bacterial. Otitis also is in majority of cases bacterial. And of course, when we go to the lower respiratory tract, it is pneumonia, which is viral as well as bacterial. Now, the reason for telling this bacteriology or the microbiology of this system is that whenever we say it is bacterial, there are three important organisms which everyone knows, like the Streptococcus pneumoniae, which at our times which we used to call as Diplococcus, okay, and now it is called Streptococcus pneumoniae. Then there is H. influenzae and there is Moraxella. And these three organisms, they are the ones, the bacteria, which are responsible for major bacterial infections of the respiratory tract. Now, over years, these organisms are showing resistance to the conventionally used antibiotics like penicillin. Now, the mechanism of resistance of these organisms and the mechanism of the pneumococcus, the H. influenzae is different. So, in case of pneumococcus, it is the alteration of the penicillin binding protein which is there on the outer side. And in case of H. influenzae, it is the production of beta-lactamases. And the beta-lactam antibiotics like penicillin, ampicillin, amoxicillin, and others, they are basically used in the treatment of gram-positive organisms like pneumococci. And alteration of penicillin binding proteins is the major mechanism of resistance. While for H. influenzae, the gram-negative one, the beta-lactamase production is the major mode of resistance. Now, when we are using amoxicillin in the dose of 40 to 50 mg per kg, that's fine. Traditionally, we have been using, quite a few bodies still recommend the same dose. But because of the rise in the resistance in different parts of the world, in different proportions and percentages, we have to now think whether we have to shift from this conventional dose to a higher dose. And that is the basic purpose of discussing the increased dose of amoxicillin against pneumococcus. So today's discussion is relatively focused, so that we are discussing about pneumococcus and we are discussing about the increased dose. And my friend Dr. Bhaskar Shenoy will elaborate on various aspects of pneumonia and the antibiotic therapy. And then we will go through a few questions wherein the concepts related to the use of amoxicillin or amoxiclav in the management of these respiratory infections will be clarified for our audience. So Bhaskar, you can start off with your presentation for a while, and then once your presentation is over, we will go to the questions which probably arise in our minds and also in the minds of the delegates. Thank you.
Thank you, sir. Thank you for the opportunity and kind introduction. Krishna and Sureka and the whole team of Micro for organizing this excellent symposium on emerging trend in the treatment of pneumococcus. So I am supposed to talk about the pneumonia, and then after that we will be discussing about the various aspects in the management of that, including other respiratory infections like otitis media and others. So without wasting much time, I'll go to the presentation. If we first, I'll talk about the pneumonia. So pneumonia is one of the diseases which claims most of the lives of children across the world. It is a leading cause of infection, killing about more than 2,400 children a day, and it accounted for about 16% of the under 5 deaths. If you take up the numbers, it is about 8.8 lakhs in 2016, and most of them were less than 2 years. And etiology, as Dr. Jog has told, it is mainly viruses and then bacteria. Out of the bacteria, Streptococcus pneumoniae is the number one culprit, followed by Staphylococcus and others. Of course, atypical organisms like Mycoplasma pneumoniae also are there. Diagnosis, you have various clinical criteria, clinical signs and symptoms: fever, cough, tachypnea. Child will come with the distress, respiratory distress. Signs of consolidation will be there. If it is not treated on time, or if it is progressing, you may get signs of hypoxemia. The WHO classification, if you look at the way they have given the diagnostic algorithm, and they have classified into no pneumonia, pneumonia, and severe pneumonia in a child of 2 to 59 months. That is 2 months to 60 months. That is about 5 years. If the child has cough and cold only, there is no pneumonia, but with fast breathing and chest indrawing, it is pneumonia. And the danger signs, like child is not able to drink, there is a persistent vomiting, child is lethargic, unconscious, stridor, or a child who has a severe malnutrition, they are all called as severe pneumonia. Once you suspect pneumonia, you have to stratify it. One is regarding the etiology, then it's regarding the severity. And then we have to look at the antibiotic management. This is the mainstay of the treatment in these children. First question is whether to treat with antibiotics or not. As we have to treat, because it is very difficult to differentiate between a viral and a bacterial. Then if it is antibiotic, which antibiotic, by which route, then can we switch over to oral route, then how long should we treat? As I told, all pneumonias have to be treated because it's very difficult to differentiate between a viral and bacterial. When antibiotic is given, it is amoxicillin or co-amoxiclav as the first choice of oral antibiotic in a domiciliary treatment, even for injectable in a hospitalized patient. Those who cannot tolerate, or there is some allergy, or you need an alternative, cefaclor or some macrolides are also can be used. And a pneumonia which is secondary to influenza, always co-amoxiclav is used. How should we give? So in a community acquired pneumonia, it is oral, and then a child who is very sick, who is unable to take orally, there are signs of sepsis or a complicated pneumonia, we may have to give IV antibiotics, which can be amoxicillin, amoxiclav, or cefuroxime. We have to switch from parenteral to oral. There is no rule that the whole course has to be completed IV. Once the child is able to, the toxicity comes down, the distress comes down, the fever reduces, child is able to take orally, then there is a need for changing the parenteral medicine into oral. So with that background, a case of 2 years with fever, cough, and breathlessness, has tachypnea, respiratory rate of 55 with the saturation 95 in room air. There is no retractions. Clinical signs of pneumonia are there. Here, as I told, we have to confirm the pneumonia, look at the etiology and the severity. Etiology of pneumonia is very important because that helps to make a rational choice of antibiotics. In a child who is 1 month to 3 months, the etiology common are Streptococcus pneumoniae and chlamydia, viruses, etc. Uncommon are Group A, Group B Streptococcus, H influenzae. In a child between 3 months to 5 years, Again, it is Streptococcus pneumoniae, and then RSV is another important organism, Mycoplasma, Staph aureus, H. influenzae. More than 5 years, again, Streptococcus pneumoniae and Mycoplasma takes a upper hand along with the viruses. So if you notice this chart, the table, in all age groups, it is the Streptococcus pneumoniae which leads the etiological factors. So in this child, what are the actions that you are going to take? Do you give oral amoxicillin at 40 mg per kg? Do you give oral coamoxiclav at 45 milligram per kg? Coamoxiclav at 90 milligram? Or you will admit, or you will give ampiclox. So non-severe pneumonia, the first line would be amoxicillin, then amoxiclav. Then there is a question, as Dr. Jog has discussed, whether it is 40 mg or 80 to 90 mg. These are the few questions that we have to answer. In a complicated pneumonia, which can be a severe and complicated, the signs and symptoms may be much more severe than what it was in the previous case. The high fever with the tachypnea, grunting, even they can develop cyanosis with a prolonged capillary filling time and reduction in the saturation, oxygen saturation. Complications, these are known to develop complications. They can be pulmonary complications or extrapulmonary complication. When it comes to pulmonary complication, the parapneumonic effusion, empyema, necrotizing pneumonia, pneumatocysts, lung abscess, embolism, pneumothorax, ERDS. These are the life-threatening complications which, if we are not treating on time, they can lead to devastating results. Whereas extrapulmonary complications like pericardial effusion, the disseminated sepsis, or SIADH. The etiology, most of the cases of the severe pneumonia, it is Staphylo or Pneumococcus. Pneumococcus is also a culprit. But in a Staphylococcus, it's the MRSA or MSSA which produce what is called as a PVL, a pentavalent leukocidin. That strain is known to cause the severe pneumonia. Whereas when it comes to the pneumococcus, there are various serotypes. The serotype 3 or 19A are known to cause the severe forms of pneumonia. There are, if you know, you may be knowing that there are more than 100 serotypes, out of which few serotypes are very dangerous, and in that 3 or 19A are known to cause severe complicated pneumonia. This table just shows you the antibiotic choices. So if the organism is susceptible, Streptococcus pneumonia, then amoxicillin or amoxiclav. Similarly, if it is intermediate resistant ceftriaxone, Staph aureus, you use clox or cefazolin, which if it is MSSA, if it is MRSA, you can use vancomycin or clindamycin, depending on the clinical situation. The duration of treatment in an uncomplicated pneumonia or a severe pneumonia, it is 5 days. Very severe pneumonia, if it is uncomplicated, it is 1 week, and it is a complicated pneumonia, it is 1 to 2 weeks. A staph pneumonia, usually it is complicated and the duration is much longer, especially those with the empyema and etc. It should be 4 to 6 weeks. When the child doesn't improve, you have to look at the compliance, you have to look at the complication, you have to look at the coexisting disease. There are 3 things, 3 C's that you have to see: compliance, complications like effusion, empyema, then necrotizing pneumonia, metastatic infections. Coexisting disease, like child has cystic fibrosis or primary immunodeficiencies. Once you, the summary of this is that if there is no pneumonia, there is no need for antibiotic. If there is pneumonia with only fast breathing, oral antibiotic. But chest intervening is there, they look for danger signs and then go for parenteral antibiotic. Very severe pneumonia, you need to hospitalize, you need to give IV antibiotic, you need to give oxygen and other supportive treatment. Having said that, let us move on to the acute otitis media, which is very common infection which we see in the office practice. I will not go into the details of that, but what we need to know is that the common organisms causing otitis media is one is Streptococcus pneumoniae again, then H. influenzae, and then Moraxella catarrhalis. And as I told, it is very common, especially in children less than 6 years. The prevalence is much higher, and the process is that it starts with the upper respiratory infection. The inflammation blocks the eustachian tube, and then the fluid accumulates, gets infected, and that results in the otitis media. And if it is not treated, the purulent discharge might come from the ears. And generally, they come with acute severe pain. One of the most common presentation is the severe pain, high temperature. Then they will have reduced hearing, and sometimes the signs of upper respiratory infections in the form of nasal discharge or cough. We have to do a otoscopic examination, which is very important that all the clinicians, especially pediatricians, keep a otoscope in the clinic and then see. Tympanocentesis, of course, to get a microbiological diagnosis may not be very practical in the routine practice. So management, you immediately reduce the pain with some painkillers, but most important thing is that antibiotics. In a routine case, you may give amoxicillin, amoxiclav, but in a recurrent or resistant cases, you have to go for amoxiclav. The concept of high dose amoxicillin with clavulanic acid, as Dr. Jog was mentioning, this is in a proportion of 14:1. That means the regular amoxicillin will be either 200 into 1 or 200 milligram amoxicillin or 400 milligram amoxicillin. This is 600 milligram amoxicillin at a ratio of 14:1. So this acts that high dose amoxicillin with clavulanic acid acts against Streptococcus pneumoniae, which are penicillin sensitive, penicillin intermediate resistant, penicillin resistant. All three categories of Streptococcus pneumoniae, this will have action. It will have action against H. influenzae and Moraxella catarrhalis. The problem with these two are that these H. influenzae and Moraxella catarrhalis, they produce beta-lactamase enzyme, thereby destroying the amoxicillin. And this Moraxella catarrhalis and influenza are resistant to regular doses of amoxicillin and amoxiclav. And when you increase the dose of amoxicillin, increase the concentration of amoxicillin, these resistant organisms also can be tackled. Now, you may ask the question, you have increased the dose of amoxicillin, but you have not increased the dose of clavulanic acid proportionately. Why? That is because, see, it is more of a pharmacokinetics of the drug. If you increase the the concentration of amoxicillin as it increases, the dose as it increases, the concentration will also increase. The time above MIC is more important. That means MIC is minimum inhibitory concentration needed to inhibit that particular organism after overnight incubation. If the dose or the level of the antibiotic is above MIC and the duration or the time period above which it stays, that is very important. So if amoxicillin can be given at a higher dose, the time above MIC increases and which will have action. But clavulanic acid, whether you give 42.9 or higher dose, the effect on the beta-lactamase is the same. So there is no need to increase the clavulanic acid, but increase the amoxicillin. That is the principle of increasing only the amoxicillin. So the rationale, as I told, is that see, penicillins are known to be very sensitive. Streptococcus pneumoniae are known to be very sensitive to penicillins. But of late, the MIC of Streptococcus pneumoniae is increasing. It can be up to 2 milligram per liter, or sometimes in a severe case, it can be up to 4 to 8 milligrams. But 4 to 8 are not seen frequently. The other important thing is that Streptococcus pneumoniae, they do not develop resistance very fast. That is because, as in the introductory section, the moderator has told that it develops the resistance by what is called as a different mechanism. It is by alteration of penicillin binding protein. There are various penicillin binding proteins. The alteration of that is the reason for resistance in Streptococcus pneumoniae. And Streptococcus pneumoniae are not a very intelligent organism, in the sense they don't develop resistance very easily, very frequently. Whereas the Moraxella catarrhalis and the H. influenzae, they are notorious to develop because they develop resistance by a different mechanism. That is, they develop resistance in a different mechanism by beta-lactamase producing. So this increased concentration of amoxicillin in that high dose combination has an effect against all these strains and all these resistant organisms also. So this high dose has action on Streptococcus pneumoniae, Staph aureus, Streptococcus pyogenes, and other gram-negative like Haemophilus influenzae and Moraxella catarrhalis. And mainly these are indicated in recurrent or persistent AOM. The child has very frequent occurring otitis media, or you have given a course of antibiotic and still again the child starts developing frequently. Or if you are able to demonstrate that this particular infection is due to beta-lactamase producing H. influenzae catarrhalis. If you look at the incidence of this resistance, now it has been found that Streptococcus pneumoniae with intermediate resistance to penicillin is to the tune of 40 to 50%, not only in India, across the globe, especially in Southeast Asia. But luckily, Indian data shows that the Streptococcus pneumoniae is still not much having resistance to that. Whereas H. influenzae have beta-lactamase produce ESBL to the tune of about 50%, but Moraxella catarrhalis is resistant to the tune of 90%. So that is a scary situation. These can be given at this 90 milligram per kg per day, and adverse effects are very less. And by increasing the amoxicillin, it is found that the increase of adverse reactions like diarrhea have not been proportionately higher. Let us see some clinical trials that are taken place in that. One of the path-breaking papers, if you can look at in the pediatric infectious disease by Dagan et al., who is a master in otitis media research. So he is one of the first persons who could demonstrate that bacteriological and clinical efficacy is much better compared to other antibiotics in otitis media. So the findings are that the if you look at here, the bacteriological success versus clinical success. When you use amoxicillin clavulanic acid, the success rate is to the tune of 86% whereas with azithromycin, the red bar here is about 40%. Similarly, clinically also, more than 90% success with amoxiclav and 65% only with azithromycin. So, bacteriological and clinical success of amoxiclav was much higher compared to azithromycin. And what he did is, he did a open label multi-center study with more than 500 children, and they gave 90 milligram of amoxicillin per day in 2 divided doses for 10 days. They could perform a tympanocentesis and they could demonstrate the Streptococcus pneumoniae. The therapy clinical response was assessed at the end of the therapy. The eradication of the organism was demonstrated in 96% of the cases, and symptoms and clinical findings also were evaluated. And the good thing is that even H influenzae were reduced to the tune of 94%. And clinical response of eradication of Streptococcus pneumoniae, H influenzae, you can see it is more than 90% of all the organisms. So there is another paper by White et al. Again showed that amoxicillin, clavulanic acid, a combination has a great effect in eradication of Streptococcus pneumoniae and H influenza. It is more than 94% of the cases. Again, in the another Hoberman et al., they studied about 730 patients with high dose amoxicillin, and they found that more than 90% of cure rates, which you can see in these charts. The safety was also evaluated, and the clinical response was good in various other studies. And most of these studies have used a microbiological proof by doing a tympanocentesis. There are some guidelines. It is not only that these studies, but there are guideline recommendations. American Academy of Pediatrics has recommended it. Initially, from early 90s, the amoxicillin was recommended. Then maybe early 2000s, the amoxiclav and then high dose of amoxiclav was recommended somewhere from 2005 or so. So now the recommendation is that the children who have taken amoxicillin in previous 30 days, a child who has recurrent or persistent otitis media, or a child where you need to give a cover for beta-lactamase positive H influenza and moraxar catarrhalis, we have to initiate high-dose amoxiclav therapy at the dose of 90 milligram per kg per day of amoxicillin. That is a ratio of 14:1. If you look at the Indian National Antibiotic Guidelines also, mentions that acute otitis media, amoxiclav at 90 milligram per kg per day is recommended. ICMR recommendation also falls with the same line. So, to summarize, what is the rationale for high-dose amoxiclav as empirical therapy in otitis media? The penicillin-resistant streptococci has no response to conventional dose of amoxicillin. Conventional dose means 40 to 50 milligram per kg. High dose, that is about 90 milligram per kg, provides increased middle ear fluid antibiotic levels that surpasses MIC of both intermediate and resistant streptococcus, and that achieves a maximal bacterial killing. Non-typeable Haemophilus influenza is responsible for AOM in nearly 50% of the cases. And as I told, about 50% of the H influenza and 100% of the Moraxella catarrhalis are beta-lactamase positive. In contrast to penicillin-resistant Streptococcus pneumoniae. AM caused by H. influenza moraxella requires a beta-lactamase inhibitor such as clavulanic acid, a second or third generation cephalosporin, or other antibiotics. So, amoxicillin clavulanic acid continues to be effective against most of the pathogens, both in respiratory and all the respiratory, including AOM. This combination has rapidly and extensively penetrates into mid-layer fluid in pediatric patients, and it is effective against Streptococcus pneumoniae, H. influenza, moraxella doses. It reduces the mid-layer effusion duration, the risk for persistent mid-layer effusion, and conversely, the hearing loss in children receiving that. It offers optimum treatment of AOM. It ensures coverage of penicillin-resistant streptococci, those with less than 4 microgram per milliliter, as well as beta-lactamase producing H. influenza, moraxella catarrhalis. Thank you very much for your patient listening. Thank you.
Right. Thank you, Bhaskar, for that presentation, and it has clarified quite a few concepts related to the respiratory infections and the use of antibiotic therapy. And some of our delegates have some relevant questions, and we will just try to discuss out. I am sure that whenever we discuss about the resistance of all these organisms to the penicillins, I always like to give the example of a dean of a medical institute who is sitting inside the room and he doesn't want to see the visitors. Okay, and then what are the mechanisms that he uses to see that he doesn't get visitors? Okay, so first of all, he will put a big lock to the entrance gate. That is, to avoid the impact of penicillin. So the penicillin binding protein is like the lock, and we will have to really increase the man force to open this lock, and that is exactly the increase in the dose from 40 or 50 milligrams to 90 milligrams. So more number of people are employed to open this particular lock, that is the penicillin binding proteins. Okay, of course, now Bhaskar, there is one listener who wants to know that pneumococcus is no doubt responsible for otitis media and pneumonias, but it also produces meningitis. So he wants to know whether this increase in the dose of amoxicillin can be rather extrapolated to use of this particular antibiotic in increased dose for the treatment of pneumococcal meningitis. So what is your take on that?
See, pneumococcal meningitis, in fact, recently there has been reports of increased penicillin resistance or increased MIC of CNS isolates. See, meningeal isolates and non-meningeal isolates, these are two different things. In the sense, the meningeal isolates are more resistant. And if you look at the paper from CMC Vellore, Dr. Balaji has clearly mentioned that there is a increased resistance of the MIC in meningeal isolates. CNS infection being a very dangerous, and we have to act very fast. As of now, the first choice is ceftriaxone with vancomycin. Of course, the question asked is, of course, logically correct, but in an infection like CNS infection, meningitis, we have to go by only ceftriaxone and vancomycin to take care of the resistant organisms, Streptococcus pneumoniae.
Right. So if I say, basically the example of the dean that I gave, the dean is rather sending tear gas, to dispel the people. and only the superintendent of police, that is ceftriaxone, can take care of this tear gas, isn't it? So that resistance can be overcome only by ceftriaxone. I'm glad that
vancomycin is, we have to add a vancomycin, not only ceftriaxone.
So the initial treatment of meningitis includes ceftriaxone plus vancomycin. And I am sure that pediatricians who are in the audience would always start with these two. And maybe later on, there could be a recommendation in case if the culture facilities are agreeable, one of these, antibiotics can be withdrawn. Is it true? Can you withdraw?
Vancomycin can be withdrawn.
Right.
If the isolate is sensitive to ceftriaxone.
Correct. So that's a very good, important clarification. Now, Bhaskar, there are quite a few in the audience who use, antibiotics without much of knowledge of, the mechanism, resistance, and so on. So they keep using amoxicillin, sometimes amoxiclav, sometimes azithromycin, sometimes some other oral cephalosporins like cefpodoxime or cefuroxime or cefaclor. So what is your opinion and take about these, 3 or 4 molecules like cefaclor, cefpodoxime, where, people are really not aware of as to which one to use. So whichever is handy and whichever comes to their mind, they are using. So is there any way to rather go ahead for our listeners?
Yeah. Sir, whenever you make a rational choice of antibiotic, 2 questions you have to ask. What is the bug? What is the drug? These 2 things you have to ask yourself. It is not only for AOM, I am telling, for any other thing, even pneumonia or gastroenteritis, UTI, whatever it is. What is the bug? What is the drug? As you rightly mentioned in the initial introduction, the bug responsible for otitis is Streptococcus pneumoniae, Moraxella catarrhalis, H. influenzae. You have to select an antibiotic which acts against these organisms. Amoxicillin is the number 1. We have used that for years together, but of late they have developed a resistance. Streptococcus pneumoniae, as I told, has developed intermediate resistance, and then penicillin resistant pneumococcus is also there. Maybe the proportion is very less, but what we are concerned is the Haemophilus influenzae, which has developed a mechanism for resistance by beta-lactamase production, and to the tune of 50%, and then Moraxella to the tune of 100%, they are resistant to the plain amoxicillin. So that can be overcome by adding a clavulanic acid, which is beta-lactamase inactivator. So amoxiclav is the number 1 treatment for these cases. That is one thing. The second thing, your question is, can others be used? Always we should be rational in selecting, not blindly just because XYZ told you are using. Cefixime is not a good drug for otitis media because it doesn't act against Streptococcus pneumoniae. Of course, ceftriaxone, if you look at the literature, ceftriaxone is the number 1 drug. The best drug would be ceftriaxone, but 3 days course, intramuscular. But the problem is you have to get intramuscular injections. You have to go to the medical care facilities. These are certain things. Now, when you increase the concentration of amoxicillin as high dose amoxicillin, that has been found to be equal to ceftriaxone. So amoxiclav with high dose amoxicillin becomes the number 1. It is by scientific evidence that I am telling. So when the child is not responding, or there are some organisms which are not responding to this, very rarely, then you can go for other macrolates and other things, but these are not the first choice. Clindamycin also in a resistant case can be given, but these are not choice. The first choice and best choice, amoxiclav.
Thank you for clarifying that point. And you have already shown the study by Ron Dagan, where amoxicillin is far superior to azithromycin. And of course, to some extent, it also probably depends on the middle year concentration of some of the other antibiotics, which is not that great. Now just one more question.
Now, before that, I will tell you, sir, the
Yeah.
concentration of amoxicillin in the serum and middle ear fluid are almost same. That is something very nice, because the barrier between them is one epithelial cell and a basement membrane only. So it is most of the sites of action, the concentration may not be that much, but here the concentration has been found to be almost equal to the serum concentration, which is a very good. That's the other reason. That is because the middle ear is highly surrounded by highly vascular capillaries, and they are responsible for the high concentration.
Right. And probably this is not true for the ones, like the other oral cephalosporins,
Yes,
maybe. Yeah. And now, there are some important points which one of our listeners wants to know. And, he says that I have started with 40 mg per kg of amoxicillin, and how to know that he is not responding in a child, suppose who has otitis media, as he has diagnosed it by otoscopy. And now he wants to know, when do I step up to 90 mg per kg? So what is your take on that?
Yeah, suppose if you started with the 40 mg, the child should respond within 48 hours. 48 hours, the fever will come down, the pain has to come down. If there is no clinical improvement within 48 hours of starting an appropriate dose of amoxicillin, that is the time that you have to step up to amoxiclav. That is number one. The second thing is, there are other situations where you have to give a higher dose. One is a child who has recurrent otitis media. You have properly treated with amoxicillin for a 10 days course or 14 days course, and the child keeps on getting otitis media. A child who has recurrent otitis media, a child who has persistent otitis media, a child who has otitis media with effusion which is persistent, and these are a few cases that needs higher dose.
Thank you. So it probably means that after 48 hours, if the child doesn't have relief from pain and fever and others, then it is likely that these organisms are maybe intermediate resistant or so. And that's why probably they require amoxicillin. Am I right?
Yeah. Yes, sir.
Yeah. Now, the same medication, that is amoxicillin, in case if we have to use it for the treatment of severe pneumonia without hypoxia, the child has come to the OPD, you find that he has increase in the rate, but his oxygen saturation is okay. Now, can we go ahead and use this high dose amoxicillin clavulanic combination in those children? Or it is only for OPD treatment of usual, what we call garden variety of pneumonia, where child is okay, no distress, everything okay, only you find bronchial breathing and, so what is your take on that?
Sir, if you look at the WHO guidelines, it says first choice is amoxicillin.
Okay.
Yeah. And whatever guidelines we see, our first line is amoxicillin. But having said that, when you use the amoxicillin and then within 48 hours, if there are no response again, that is one thing. Now, if you look at the present national guidelines on antibiotic therapy, the recent guidelines, Indian guidelines and American Academy of Pediatric Guidelines, they all recommend amoxiclavulinic acid as first line. So you can use amoxiclav, higher dose of amoxiclav as first line in these cases.
Okay, thank you. So we can use as the first line medication.
Because there are recommendations. It is not that I am telling, there are recommendations.
Right. And can we extrapolate it to IV amoxiclav? That means this increased dose amoxicillin, because outside we do get that means preparations which have amoxicillin and clavulanic acid. Do you suggest that in case if I'm treating a child, now usual tendency of our colleagues is to admit the child and give ceftriaxone. Of course, some are there who usually start with amoxiclav IV also. So In that particular preparation that we use intravenously, the amoxiclav preparation IV, there also the rule is the same where amoxicillin should be 90.
Yes,
Yeah.
sir. Yes,
Yeah.
sir. Those conditions say those indications where you use high dose amoxicillin, it can be if the child is sick and child is admitted, you can give. But I'm not sure whether there is high dose amoxicillin IV preparation is available. Krishna or Sureka? High dose IV is available? No. No, no. So high dose IV is not available. But given a choice, if it is available, I would recommend, because the indications are same. Only thing is later, once the child is stable, you are shifting it to oral with the same dose.
Right. Thank you very much. So, we have almost all our queries clarified related to otitis media and pneumonia, because they are probably the important indications where we are using high dose amoxicillin, different conditions in otitis media and also in case of pneumonia. I think in case if there are any other queries, Dr. Krishna, from your side, you are free to ask them. Otherwise, I would just say that this particular resistance to pneumococcus, which fortunately in our country is not to that extent, we should be happy about it. But in case if there is an indication, we can go ahead and use high dose. Yes, Bhaskar.
Sir, when you told that incidence is not high, one is because we are not doing the tests.
Okay.
We to prove that the resistance is high and the organisms are resistant, you need to do tympanocentesis, culture the fluid. In India, how many studies are there to say that it is? So only the clinical correlation wherein the child is not responding to the conventional, then you can suspect. We don't have the like Dagan, who has done, Ron Dagan has done a study. We don't have a study wherein the fluid was taken, and these studies are very lacking. Of course, they say in India, the Streptococcus pneumoniae is very sensitive to penicillin. Of course, but we have not done a large scale studies to prove or disprove that. That is one thing. The second thing is the Ron Dagan, he has his study, all the 500 or 600 cases, they were microbiologically proven, but we don't have that study. That is one thing. So a child who is prone to develop these resistant cases, who are those children? A child who is below 6 months, who develops otitis media, we have to be cautious. A child who develops recurrent otitis, a child who has persistent otorrhea despite your antibiotic therapy, a child where there is parental smoking, that is one of the risk factors for recurrent and persistent otitis, and a child who is on bottle feeding. These are a few risk factors we have to look at, and these are children who get recurrent otitis media.
Yes, thank you for elaborating that. And I must say that approach to the middle ear cavity and to get that fluid is a bit difficult, and that's why many of our even the postgraduates to whom we give these topics for dissertation, it becomes difficult because again, parents may not agree to all that. They take that otitis media, is a common thing in childhood, and that's why this particular invasive procedure may not be agreeable to all. That's fine. Bhaskar, if you have any important point to be rather told about this particular increase in the concentration of amoxicillin, you can freely tell that. Otherwise, I would just say that the indications have been elaborated to a great extent, and I would always say, when we discussed about the resistance, I used to use the word sir. Sir, thank you. So, sir, S stands for sensitive, I for intermediate, and R for resistant. So, the pneumococcus, I always say pneumococcus sir, okay, because he is either person is sensitive or intermediate resistant or totally resistant. So, we have discussed about this pneumococcus sir, It's a very, very, tricky organism. And I must say that today on this day of Sankranti, let us rationally have the Sankraman, that is transition from 40 to 90 milligrams, isn't it? So let us not be very hasty, but let this Sankraman be slow, and this enhanced strength preparations which have been brought into the market, particularly let them bring extra sweetness, because on the day of Sankranti we usually give that combination of sesame and jaggery, till and good at our end, so that makes sweetness, that brings sweetness. So that let this extra strength preparation bring extra sweetness in the life of children with respiratory infections. So thank you, Bhaskar, for guiding the audience. And I particularly tried to keep the discussion simple, because then to make it complicated is easier, but to keep it simple is more difficult as far as this pneumococcal resistance is concerned. Thank you very much. And I hand over to Dr. Krishna and Sureka for concluding this particular session. Thank you.
Thank you very much, sir. And sir, there are no queries here. There are more accolades coming in other WhatsApp groups here. They are telling, thank you, Bhaskar sir, for the clinical pulse, and to make it much easier. This is a couple of PG students writing in here. And for jokes, sir, especially there is the Sankraman, they're liking it, and they're telling, yes, sir, this new horizon we will try to incorporate in this practice. So they're asking one don't from you. You're telling all the do's. What is that don't which you want to give it to me? That is what I think this is Dr. S.A.R. I think a PG student from Lucknow.
Only don't that Bhaskar has said, don't use cefixim in the management of otitis media. That is one don't. And also remember, to use these preparations and don't keep them at room temperature. They are to be kept in the refrigerator, because otherwise we have seen so many times these preparations, they will change their color. So don't keep them at room temperature, and don't use cefixim in the management of otitis media, neither for pneumonias.